rounds. Dr. Lederer is out of the country, so she asked me to go ahead and introduce the speaker. And I'm Christian Furman. I'm the interim division chief for the Division of General Internal Medicine, Palliative Medicine, and Medical Education. And I want to introduce our speaker, Dr. Laura Fanucchi. So Dr. Fanucchi did her undergraduate training at Swarthmore College in Pennsylvania and went to Emory for medical school and did her internal medicine residency at New York Presbyterian Hospital, and then served as a chief resident for quality improvement in internal medicine. In 2017, she did an immersion training in addiction medicine at Boston University School of Medicine, and she's been faculty at the University of Kentucky since 2012. She recently became a buprenorphine waiver course instructor, and instead of a lot of continuing education, a lot of extra training in addiction medicine. She's published numerous articles and been PI on grants. And today she's going to be talking about the opioid epidemic, what we can do in internal medicine. She came and presented a summer grand rounds that our division had about a couple months ago, and we were so impressed, and she changed all of us. And like in 2 months, it's amazing how much we've been able to implement a lot of what she said and changed hearts and minds around this. And so we really thought the whole department should benefit from her expertise. So Dr. Fanucchi, thank you for coming.
Yes? No? A light. Maybe I can just, they can hear me this way. There we go. Will it feedback if I stand here? Okay. All right, thank you all so much for having me. It's delightful to be here. I'm sorry if some of this is I tried to update it a bit from what we went over a couple months ago, so that if some of you are here, they were also here in July, it's not too repetitive. I do not have any conflicts to disclose. And today I was hoping to go through that opioid use disorder is a medical disorder that can be treated in the outpatient and inpatient setting. We're going to go through pharmacotherapies for treatment of opioid use disorder and review some strategies for inpatient buprenorphine induction and management. And then I'm also going to share with you some of the research that we've been doing around this issue, specifically with respect to patients hospitalized with severe and infectious complications of injection drug use. So I'm sure a lot of you have seen these slides, but essentially over the last almost 20 years, we've had 3 waves in the rise of the opioid epidemic, opioid overdose deaths. So we started with, unfortunately, exposing a large swath of our population to prescription opioids. And as rates of prescription opioid overdose deaths started to increase, then unfortunately heroin came in, and with different mechanisms of distribution in an already opioid exposed community. I'd encourage you, if you haven't seen it, to read the book by Sam Quinones, who describes the sort of pizza delivery style method of heroin distribution that was able to enter many of our communities. And then what's really taken off in the last few years is actually fentanyl. So this is synthetic opioids like fentanyl, and that's why we have not seen a downtrend in our rates of overdose death. So illicit fentanyl is a synthetic opioid that's almost about 100 times more potent than heroin, and this is a lethal dose of fentanyl. So these are from the DEA website. This is a lethal dose of heroin, a lethal dose of fentanyl, and a lethal dose of carfentanil. So that's that elephant tranquilizer that there were all these news reports about cops getting a little bit on their uniform and then overdosing in the field. So again, to show that there's just been such an increase in the supply of fentanyl in the drugs that have been seized by the DEA. And this is in the context of now we're almost up to 50,000 opioid overdose deaths in 2017. And this is, again, mostly fentanyl. So along with the epidemic of opioid overdose deaths, you all are seeing, as we are in Lexington, just so much hepatitis C. And then we've had the hepatitis A outbreak as well, right, which is associated with drug use. And the CDC modeled, so they did a study in 2016 modeling the counties most at risk in the United States for an outbreak of HIV associated with injection drug use. And a huge percentage, so these are the green are the 220 counties in the United States most at risk. And this is the top 5% out of the more than 3,000 counties that we have in the United States. And 50% of them are in Kentucky, in our area. In addition, there have been a dramatic increase in the number of hospitalizations for opioid use disorder and associated infections. So this is a retrospective study of endocarditis, rates of endocarditis, osteomyelitis, et cetera, compared from 2002 to 2012. And we've seen these only increase, and I'm sure you all are experiencing this in your hospital, as are we. So substance use disorders are really common in hospitalized patients. As it turns out, about a fifth of hospitalized patients have a non-alcohol, non-tobacco substance use disorder, and that has been increasing over the last decade. The problem is that it's frequently not recognized by inpatient teams. So we did a retrospective review of 125 patients with infections and injection drug use, and the documentation from the clinical teams was mostly limited to IVDU and IVDA, and fully half of the charts had no mention of the specific drug being injected or being used. More than 80% of the chart had no plan for treatment at all, even when we have opioid use disorder has effective medical treatments. And I'll remind you that unfortunately, IVDU and IVDA are actually not medical diagnoses, so there's no ICD-10 or ICD-9 code that links to that word. And so not only are we not adequately clinically diagnosing and then managing our patients, but then if you think about population level estimates of this epidemic and how we need to really respond effectively, these large data sets are based on the documentation that we put in the chart, right? So codes are abstracted from our documentation. And if our documentation doesn't support a diagnosis code, then that diagnosis code doesn't go into the large data sets. And so we have an underestimate, really, of how many patients we're touching in the hospital that have untreated substance use disorder. Opioid use disorder and substance use disorder complicate hospitalization. So somewhere between 10 and 30% of these patients leave against medical advice. And there's a lot of complicated reasons for that, but a lot of them, for opioid use disorder in particular, there's really very real complicated withdrawal, pain, and craving for opioids that are not adequately treated in the inpatient setting, and patients leave. And then when they have complex infections, we tend to keep them in the hospital for weeks to finish IV antibiotics, and those prolonged hospitalizations, these patients have lives outside the hospital. A lot of them have children, they have financial and social obligations. It is really hard to stay in the hospital for 6 weeks. And then on top of that, when someone has an opioid use disorder and is opioid dependent, we tend to taper people. And this is not only very unpleasant for the patient, but we make them lose their physiologic tolerance, and that's actually quite dangerous, especially with the amount of fentanyl that we now have in the community. So with loss of physiologic tolerance, which happens with an opioid taper, you lose the tolerance, and then you have a greatly increased risk of overdose death. So to use, if you'll bear with me while we do a little bit of a thought experiment. We all agree that coronary artery disease is a chronic relapsing medical disease. There are both non-modifiable and modifiable risk factors, right? So this is well known. A lot of the modifiable risk factors, then it's kind of this endless feedback circle, right? So some of these modifiable risk factors affect the likelihood of developing these problems, which then affect the development of this problem. And I think you'll agree that with the modifiable risk factors, there are environmental, behavioral, and societal and cultural factors that influence all of these behaviors. Similarly, with addiction and opioid use disorder, there are non-modifiable and modifiable risk factors. It's the same concept. Addiction is a chronic relapsing brain disease. There are genetic factors. There are genetic differences in how we metabolize opioids. Some patients, some people will take an opioid for the first time and feel nauseous and get a histamine response, and it's really not so fun, and it's not reinforcing. They get sleepy. Whereas some people take an opioid for the first time and they feel energized. They feel a tremendous sense of well-being. If you ask patients who develop opioid use disorder, what were your first experiences with opioids like? Some of them will say, all of my problems went away, right? And so that's tremendously reinforcing if you have that experience. And then there are modifiable risk factors. So the availability of drugs in your community, peers using, domestic violence, early life trauma. And I think you can agree that similarly, there are environmental, behavioral, society, and cultural factors that affect these things. So getting to some of those early life risk factors for development of an opioid or substance use disorder, this was a huge survey-based study done out of the Kaiser Permanente database in California. So this was 17,000 patients in their registry. And these are not necessarily Medicaid patients. Kaiser Permanente is a private system, correct? And so they surveyed adults about the prevalence of these factors in their childhoods. Abuse, neglect, and household dysfunction with domestic violence, mental illness, an incarcerated relative, or the presence of substance abuse in the home. And the presence of, so this is now known as the ACE study, and it's spoken about a lot when people are talking about risk factors for substance abuse later in life. But the presence of any one of these factors doubled the odds of ever being addicted to drugs. And 5 of these, the odds were tenfold that the patient would ever inject drugs. So when we see adult patients that have already developed many complications of substance use, I think it's really helpful to go back in our history. And when you take a comprehensive substance use history, explore some of these factors with patients. What was your childhood like? Did anyone ever harm you physically, sexually, or emotionally? And if you kind of get this context for a patient, not only does the patient feel more understood and you begin to reduce some of that stigma that these patients experience, but you also, I think, as physicians, we then have a better understanding of where patients are coming from. So opioid use disorder is diagnosed with the DSM-5. It used to be DSM-4, but there are 11 criteria, and it's helpful to think about them as the physiologic sequelae, loss of control, and then adverse consequences. So patients develop tolerance, withdrawal, and craving with taking opioids chronically over time. And then they begin to lose control of the amount of opioid being consumed. They have a persistent desire to cut back, but they're not able to, or they spend an awful lot of time getting, using, or recovering from use. And then there's the development of adverse consequences and the continued use despite these adverse consequences. So the use of the drug means that they fail to fulfill responsibilities, they use in physically hazardous situations, they develop social and interpersonal problems because of drug use, their families and friends are upset and talking to them about it. The drug use causes them to give up or decrease other important parts of life. So the reason that tolerance and withdrawal are in a box is that if a patient is chronically prescribed opioids and they're taking them as prescribed every day, and then they don't have any of these other factors, they will have tolerance and withdrawal, right? You take away a chronic opioid that is being prescribed, they will have withdrawal. But if that's all they have is tolerance, withdrawal, and they're being prescribed opioids and they have none of these other things, they don't have an opioid use disorder. They are physiologically dependent, but we develop physiologic dependence with tons of drugs that we prescribe, right? Beta blockers, SSRIs. So how do you treat opioid use disorder? The same way you treat any chronic disease. So we screen, we assess, and we diagnose. We provide medications that are evidence-based and shown to improve morbidity and mortality. We incorporate behavioral interventions, and we step up and step down care based on the response to treatment. Our treatment goals, we don't have until I have a cure for opioid use disorder, my treatment goal is remission and return to function in life. And this is important. Relapse rates are greater than 80% with abstinence-based or detox-based programs. So there are 3 FDA-approved medications for treatment of opioid use disorder. And this is a schematic of essentially their mechanism of action. So with increasing opioid effect, you have increasing use stimulation. And with increasing acute opioid dose, each of these drugs acts differently. So methadone is a full opioid agonist, similarly to morphine, oxycodone, the ones that we use in the hospital every day. with increasing dose of methadone, you have increasing stimulation of the mu opioid receptors until eventually you stop breathing and you die. But there's no ceiling. Whereas buprenorphine is pharmacologically different. It's actually a partial agonist, so it will sit on the opioid receptor and stimulate it up to a point, and it actually has a higher affinity for the opioid receptor than most of the full agonists. And so it sits on the opioid receptor and binds and stimulates, but there is a ceiling of stimulation. So as you increase the buprenorphine dose, you don't get further stimulation. That's why it's a safer drug from a respiratory suppression standpoint. But this is the other issue with it. Because it binds more potently to the opioid receptor than full agonists like heroin, if you have a full agonist on board and you're up here and you give someone buprenorphine, you'll precipitate withdrawal because the buprenorphine kicks the heroin or whatever off the opioid receptor and they get really sick. So this is why patients sometimes say, I've tried Suboxone. I mean, it's available on the street commonly, and they might try taking it for self-management of withdrawal. That will work if they're already in withdrawal. So if your patient is already in withdrawal and you give them buprenorphine or they take it themselves, they'll feel better. But if they're here and they take it too soon, they'll make themselves sick. That's conversely an opioid antagonist. So naltrexone is the long-acting antagonist that's FDA approved for treatment of opioid and alcohol use disorders. This is different than Narcan, naloxone, which is the very short-acting opioid reversal agent. So the point of medications. So the natural history of opioid use is in the beginning periods, these are your opioid receptors, your dopaminergic tone in the brain, and this is normal. You feel okay. And with use, in the beginning, you get euphoria. But as tolerance and dependence develop, you develop withdrawal if you don't have the drug in your system. And so then use sort of begins to be required in order to prevent these negative, really horrible effects. And so the goal of agonist treatment with methadone or buprenorphine is to normalize, again, the dopamine and opioid receptor tone in the brain. So we're going to focus now on buprenorphine. It took an act of Congress, so the Drug Abuse Treatment Act of 2000 allowed us to prescribe a medication in an office-based setting for treatment of opioid use disorder. Before this, there weren't any. So as we talked about, it's a partial agonist. It has decreased overdose risk, and the naloxone component, so buprenorphine, Suboxone products, buprenorphine/naloxone, this is only there to decrease the abuse liability. So it's not bioavailable when the medication is taken appropriately. So the medication is, this formulation, this is Suboxone, the film, and it's about the size of my thumb first digit. It's sublingual, and there's a tablet formula, there's a couple different tablet formulations that are sublingual. The medicine is not bioavailable if the patient swallows it. So you have to instruct your patient to leave the medicine under the tongue or in the cheek until it fully dissolves. But the naloxone component is not bioavailable unless the medication is dissolved and injected. So that's the whole point of it. And most of the formulations have buprenorphine, naloxone in a 4:1 ratio. There are some new long-acting depot and implant formulations that, of course, don't have the naloxone component in them. So this was a study done in 2003 in Sweden, where it was already known that buprenorphine worked, but in Sweden it wasn't legal. And so this Dr. Keiko did this study to prove a point. So he randomized, so everybody got counseling. He randomized opioid dependent patients to maintenance treatment with buprenorphine versus detox, and everybody got counseling. And I mean, this is the number of people remaining in treatment at essentially 2 months. And this is a small study. I think there were only 20 or so patients in each arm. And what's really important to recognize is that 4 people in the detox-only group died of overdose within that short period of time. There was a large study and a large meta-analysis that came out last year looking at buprenorphine and methadone mortality rates for people in and out of treatment. And the summary point estimates show that buprenorphine decreases not only overdose mortality, but all-cause mortality. And this is in patients in treatment versus out of treatment. So I think this is sort of the point of this conversation is why are we still doing this, really? So imagine our person with coronary disease. He's admitted with an acute MI. He's told it's his fault because of obesity and smoking, and he's advised to call a list of cardiologists. He's told he can't have aspirin or cholesterol medicine because he's not ready to quit smoking. And he's sent home with a stern reminder to lose 50 pounds and stop smoking, or he'll probably die from another heart attack. It's ridiculous, right? We wouldn't do this. But we do this all the time with another chronic illness. So this 50-year-old man is admitted with endocarditis. He's told it's his fault because of injection drug use. He's advised to call a list of treatment programs. He's told he can't have medication and to see a counselor and go to rehab. And he's sent home with a stern reminder not to use drugs, so he'll probably die from another infection. I think that culturally we're doing this less, but we've done this for a long time, even with data that already existed, showing us that there are medications that save lives and help people. So in the inpatient setting, and I've heard that we've already started to do that, use buprenorphine in the inpatient setting here, which is amazing, and I'm so happy to hear that. But there are data, studies were done that buprenorphine can be safely and effectively initiated in the inpatient setting. And now, with the amount of fentanyl out in the community, emergency departments are starting to do in-the-moment inductions. So patients come in with opioid withdrawal or an opioid overdose, and they give them buprenorphine that minute and have them linked to an outpatient treatment program. Because right now there's increasing data that just the presence of opioid withdrawal increases your risk of opioid overdose death. And there are several academic medical centers that have started addiction consult services. So these often grow kind of grassroots out of internal medicine departments where there's a few physicians that kind of become really interested and passionate about this, and they just start seeing patients and helping their colleagues manage the underlying substance use disorder. And there have been some papers published that this really helps change cultural at the institution, and also helps with clinician and nurse satisfaction because people feel more supported. There's a lot of frustration in the inpatient setting for nursing and providers about taking care of this patient population. They're absolutely sometimes very difficult to take care of, but providing treatment can actually make a really big difference in your ability to manage inpatients with opioid dependence. A couple of years ago, we published a little perspective in the New England Journal talking about exactly this problem, the need to integrate treatment for opioid use disorder in the inpatient setting. So to that end, let's try again. So a 50-year-old patient with opioid use disorder, he has tricuspid valve endocarditis. This is the same guy. He has track marks, and he's asking for opioid medicines for pain. Now, maybe before you would see in the chart he's drug seeking, right? Or similar labeling like this. He's anxious, he's agitated, he's sweaty. What do? So we use the clinical opioid withdrawal scale to measure objectively opioid withdrawal. This is easy to find online and on MD Calc. I pull it up most days I'm working. And there's 11 criteria, and it's scored on a scale from 5 to 25. The number you're looking for to safely start buprenorphine is about 8. So how do you actually start buprenorphine? So you prepare your patient. You tell them, well, first you take a substance use history, right? And you go through, make sure that they have an opioid use disorder, that they're physiologically dependent. You see opioid withdrawal, you talk to them what you're going to do. So we're going to treat your pain and withdrawal, and you're going to be a lot more comfortable. So you stop full agonist. So let's say they're getting, 10 of oxycodone every few hours. You stop it. You say, I'm going to stop. Your last dose of oxycodone will be before bed, and then withdrawal will develop. And so you wait, and you check on the patient or ask nursing to check on the patient. They can do a COWS score. When the COWS is above 8, it is safe to start buprenorphine. And usually I give 4 milligrams of buprenorphine under the tongue. You can go up to 12 milligrams in the first day. Usually I give it every few hours, but just to give you a sense of how safe it is, the ERs that are doing this now give patients an initial 8 milligrams when opioid withdrawal is present, and sometimes they load all the way up to 24 on the first day. And that's to take advantage of the really long half-life of this medication. So if you give someone 24 milligrams of buprenorphine and send them out of the hospital, they're relatively protected from opioid overdose for probably 48 to 72-ish hours, because the medicine has a 36-hour half-life. And patients tolerate really pretty high doses without respiratory suppression. So in the hospital, I generally give up to 12 milligrams on the first day, and then I pretty quickly go up to 16 milligrams. Because in the hospital, I think that we really want to maximally manage pain, cravings, and withdrawal so that patients are most comfortable. Remember, this is a chronic relapsing disease. So we'll deal with it in the outpatient setting. This is really a long outpatient process. And don't worry too much that, the patient's going to be on 16 milligrams and really, our goal is less. No, our goal is to keep the patient safe, to keep them from having an overdose death, and then to accomplish your goals of the hospitalization, right? You want them to finish get treated, whatever problem is that they came to the hospital to start with. So the package insert says you can go up to 24 milligrams a day of maintenance. It is safer to go higher if you need to. As I said, you need to talk to your patients about keeping the pill or film under the tongue and hold the saliva until it's absorbed. This is something that's important also from the nursing standpoint. You can have them do mouth checks, make sure the medicine is fully dissolved. Don't have patients look, it tastes bad. And so patients are wanting to chew it and swallow it, and then they're really not getting the full dose of medication. They need to be taught not to smoke, eat, or drink for 30 minutes after, because it interferes with the absorption. So this patient had a successful in-hospital induction. He's much more comfortable, but then he's sick in the hospital, and he has endocarditis, and he has a big, nasty pleural effusion. And so he requires a chest tube, and he's asking you how pain's going to be managed. So talk to him about the options. It's very safe to continue buprenorphine if the patient can continue to take sublingual. There are injectable formulations that can be given as well, but if they can continue to take sublingual, that's probably easier. Use non-opioid adjuncts on top of it if it's safe to do so, NSAIDs, acetaminophen, and then you can give full agonists on top. You might have to give a higher dose, but patients will still get analgesia, and then you won't have the problem of having to reinduct later once the acute pain problem is better. The other thing to do is buprenorphine is actually a very effective analgesic. And so the analgesic half-life is shorter than the half-life of the drug on the opioid receptor. And so the analgesic effect is about 6 to 8 hours. So you can split up the total daily dose of the buprenorphine. That's not usually your outpatient goal, but in the inpatient setting, if pain is a problem, you can split it, and then you can go higher, and patients will be more comfortable. If the patient is going to be intubated and they can't take sublingual anymore, you can just give full agonists, recognize that you'll probably have to give more while the buprenorphine is still sitting on the receptors. But then, unfortunately, you will have to reinduct the same way you did before, with stopping the opioid, waiting for withdrawal, and restarting. So this is the elephant in the room, right, with management of these patients in the inpatient setting. And this is really what got me interested in this whole problem. It seemed crazy to me that we were keeping patients in the hospital for 6 weeks to manage the IV antibiotics, when there really weren't any data to do one or the other, because patients with injection drug use had been completely excluded from any studies with managing IV antibiotics in an outpatient setting. So we did a prospective study. We arranged a agreement with a residential treatment facility that they would manage the PICC line and give buprenorphine. And so once the patients were medically stable, we could theoretically discharge the patients to a residential treatment facility, and then this would be great. They would start to get some addiction treatment, and they wouldn't be sitting in the hospital for 6 weeks. And so we designed a prospective study around this to see what happened, whether patients were willing to accept this program or not. But at the time, we weren't systematically starting treatment for opioid use disorder in our hospital. And so we enrolled 42 patients hospitalized with infections. Almost all of them had endocarditis. They were young, as you would expect. Their length of stay was 38 days. And almost all of them had opioid use disorder, but only 8 accepted discharge to the residential treatment facility. And there was another study similar in Oregon where a very small percentage of patients accepted discharge to these facilities. Importantly, in a 5-month study, 7% of these patients died. The other thing we looked at was in-hospital drug use in this patient population. So we did urine drug screens that were separate from what the hospital team was doing. And we did detect about 40% of people with illicit drug use in the hospital. The problem is that it was very difficult to adjudicate the opioid use because a lot of these patients were getting opioids in the hospital. So this was a very conservative estimate, because if they had oxycodone around the clock and we detected an oxymorphone, it might have been a metabolite of oxycodone, and so we said, well, no, they weren't using illicitly, but we had no way to know for sure. Importantly, most of the illicit use was opioid related, and when we asked patients what they thought would help them not use, most of them thought that medications would help, buprenorphine and methadone. So because of both the challenges in low acceptance of residential treatment and the fact that our hospital wasn't really systematically starting medication, we then did a pilot proof of concept randomized controlled trial where patients that were hospitalized with opioid use disorder and endocarditis or osteomyelitis, a severe infection requiring long courses of IV antibiotics, we started them all on buprenorphine in the hospital. We randomized 20 patients to usual care, so completing IV antibiotics in the hospital versus early discharge with a PICC line. And everybody got 12 weeks of outpatient treatment with buprenorphine. And when they had the PICC line, we saw them very frequently. So we saw them 2 or 3 times a week in the outpatient setting. And so we had to limit our patient population to people that could get back to our clinic, and our population pulls from a large geographic area. And so we had to limit it to people that could come back 3 times a week. And our primary outcome was illicit opioid use. And our hypothesis was that that discharging patients early would be equivalent to keeping them in the hospital. Now, this is not yet published, so please don't share it if these slides are shared, but it has been presented. So, as I said, the patient population is young. Almost all of them had endocarditis, and some of them had osteomyelitis. They all had DSM-5 criteria for opioid use disorder. And there's a lot of comorbid other substance use. So there was a lot of methamphetamine use as well. Everybody completed their antibiotics. Everybody in the outpatient and this is the outpatient. Early discharge is outpatient. So everybody finished in both arms. The length of stay was almost 3 weeks shorter in the patients that were able to be discharged, randomized to early discharge. And we successfully completed an average of 20 days of IV antibiotics in the outpatient setting with a PICC line. The proportion of illicit opioid negative urines. So the early discharge group were the people that left with the PICC line. And remember, our hypothesis was equivalence. And these representation is we treated missing values as positive. So actually, if we left it as the patients that followed up, this actually would have moved up, but we assumed that if we didn't have a urine, that it was positive. And so this is actually pretty good from an outpatient buprenorphine treatment outcome. And we felt, even though our study was not powered enough to detect superiority, we felt that there was a suggestion that the people that left early actually might have done a bit better. And that holds true, at least in the initial retention in weekly physician visits. By the end of the 12-week study, the retention in physician visits was pretty similar between the two groups. So that's the end of the buprenorphine part. Unless anyone has any questions about buprenorphine. Yeah. 36 hours. I don't know that it's well known, but patients still experience some analgesia. You may need to, I don't think that it's fully understood. They don't get the euphoria, okay. But they do get relief. Yes, okay. And you may need to give more. So if has anyone ever tried healing? It is a full agonist. I don't think so. The point being, you can manage pain while the patient's on buprenorphine. So the other FDA-approved opioid agonist medication is methadone. And the only legal setting for methadone for addiction treatment is in a licensed opioid treatment program. So that's not a clinic. It's regulated at both the federal and state level. And the feds require daily dosing for the first 90 days. It's typically a liquid or wafer formulation, and the patient goes in every morning. Clinics usually start dosing at something like 5 a.m. because people that are in treatment can go back to work and function. And so they have early dosing hours so patients can go get their dose and move on with their day. And they go to the window. There's a lot of computer checks and whatnot, and they get their dose, they take it, and they go. And there's usually counseling built in. Now, methadone is a more complicated medication. There's a lot of drug-drug interactions. There's an increased risk of respiratory suppression compared to buprenorphine. And it's typically increased very slowly because it takes about 5 days to get to steady state. So patients will typically start at around 30 or 40 milligrams and then increase by about 10 milligrams every 5 days. Typical doses of methadone in an opioid treatment program are upwards of 80, 90 to 120 milligrams of methadone a day, given all at once. So in Kentucky, we have actually pretty poor access to methadone treatment. A lot of the large urban centers on the coasts have very well-established networks of methadone treatment programs that have been around since the heroin epidemic of the 80s, really. But we don't have that. And so buprenorphine is much more available because in Kentucky, I'm hoping that this will change here as part of our state's waiver, which is problematic for other reasons. But one of the good things that happened with the Medicaid waiver was that methadone would hopefully be paid for by Medicaid. Right now, it's not. And so in Kentucky, patients have to pay about $15 a day for methadone treatment, which is about $450 a month, and that's prohibitive for a large segment of our patient population. So again, evidence. 1990, this study was done in Scandinavia. Opioid-dependent patients were randomized to methadone versus counseling. Everybody got counseling, but not medication. And this is death. So this is an 8-year study, and the difference in mortality is immediate and dramatic. Just to remind us of what we do with other really powerful mortality differences, this is Gleevec and GI stromal tumors. And this is old. So imatinib was so effective that they never even did a randomized controlled trial comparing imatinib to treatment to old treatment. This is retrospective controls. But the mortality difference is immediate and dramatic, and it wouldn't even be questioned why we would use the better drug. And yet we spend 20 years not doing this. I don't really have an explanation. Again, to reinforce the point, this large meta-analysis looked at methadone, and it decreases not only overdose mortality, but all-cause mortality, which is hard to do. So France was sort of the poster child of expanding buprenorphine access and showing a decrease in overdose deaths. So in France, in the early 90s, they were starting to have an increase in heroin overdoses. And the government just unleashed buprenorphine. They just, to primary care. There were no regulations, there were no rules. They just said, give this medicine, it works. Now, you could argue maybe there's some problems with that because there are still problematic behaviors that need to be worked on in treatment of substance use disorder. However, their overdose deaths plummeted. And this is patients given buprenorphine. I'm sorry, the slide is kind of fuzzy. Maryland also did show, now I don't know that their updated data still look this good. So this was a while ago, but they were showing when they responded to the heroin epidemic by increasing the numbers of patients on buprenorphine and methadone. And they also showed an association with decreased overdose death. So the final FDA-approved medication is naltrexone. Now, there aren't mortality data for naltrexone yet. And there's concern that naltrexone may be problematic because what it does is it fully binds the opioid receptor and blocks everything else. And there's some theoretical suggestion that that actually may upregulate the opioid receptor. And so what happens is with opioid use disorder, the recommendation is to use, there's both an oral and an injectable formulation. The oral form is once a day pill. There's an obvious problem with that, right? The patient doesn't take the pill, they're no longer blocked and they can easily overdose or use. The injectable is monthly. And the problem that we see in studies is that patients come for maybe 1 or 2 months and then they stop coming back for the injection. There's nothing innately reinforcing about this medication. Methadone and buprenorphine do have reinforcing benefits and patients want to stay on those medications. The problem is that when they stop coming back, their tolerance is completely and totally gone, and they may have some upregulation of the receptor. And so the risk of overdose after that may actually be higher. So there's a lot of interest and political interest about naltrexone. It kind of scratches all those good itches about, well, it's not an opioid, so patients can't abuse it. Well, that's true, and that's great only if it works, as far as I'm concerned. So there's some data from the criminal justice population because for a long time in jails, no one was given methadone or buprenorphine. And so patients would detox in jails, they'd lose physiologic tolerance, and then there were all these media reports that people would get released from jail and go use and die. And so they gave patients extended release naltrexone upon release from jail. And in 25 weeks, there was an improvement in the number of patients that had relapsed versus not in patients that received naltrexone. There was finally a head-to-head study just published last year. It took them forever to get this study done because patients don't they're not typically motivated for this medication. They don't want it. And it seems that once you get people on the medicine, at least for 24 weeks, the probability of relapse is similar between buprenorphine and extended release naltrexone. However, there was a big problem in getting people on it. So this time lag here was patients dropping out of treatment before they even started the medication. And the problem with starting the medication is you have to have the patient go through withdrawal. And that in and of itself right now with the amount of fentanyl in our community is risky. So I do have some patients in my outpatient setting on this medication, and they're typically patients that are highly motivated specifically for this medicine. So there are some people that still feel strongly that they don't want to be on an agonist at all. They want to be on Vivitrol or naltrexone, and I'm happy to support them in that. And so they're on this medicine. This is not a majority of my patients at all. And then there are some that have been to jail and already detoxed, or they're in an abstinence-based residential setting. So unfortunately in our state, there still are a number of residential programs that don't allow their clients to be on medication. And so they've detoxed in these residential programs and lost physiologic tolerance. And so they are interested in being on the blocker. And then I'll leave you just with two last points. So please prescribe naloxone to your patients upon discharge and in the outpatient setting if they have, if they use opioids, if they have someone in their family that uses opioids, if they're prescribed opioids, if they're prescribed opioids and benzos. I really think the more of this we can get onto the community, the better stand our chances of trying to decrease the numbers of patients that are dying every day. And then refer your patients to syringe and needle exchange programs. So the Kentucky Harm Reduction Coalition keeps a nice updated map of the existing syringe exchange programs in our state. And there are good data that syringe exchange programs reduce HIV transmission, increase recruitment into treatment, and decrease law enforcement needle sticks. And it is cost effective. And I'll leave there with a couple minutes for questions. Yeah. No. So there are, I didn't show those slides, but there are data that show that people people in a tapering condition don't do well. So they relapse is the problem. So if patients want to taper and they feel really strongly about it, then I approach it from a long-term standpoint. Okay, we can let's get your life back together. Don't focus so much on coming off the medicine immediately. Let's let the medicine support you in getting your life back. What are your goals? Let's meet some of those goals, or all of those goals. And then once all of that is stable, if you really feel strongly about decreasing the medication, then we can do that slowly over a long term. And then if you do that, it's okay. And you find that you can't tolerate it, it's okay to go back up. But there are definitely some patients. So one of my colleagues is an addiction psychiatrist and has been doing this for a really long time. And she has some patients that are working full time, raising families, have been on buprenorphine for years. They wanted to taper. And there's this 2 milligram problem where it seems like still even 2 milligrams of buprenorphine is pretty physiologically active. And without that, they feel horrible. And that's the other role for some of these implantable formulations. So there's a rod formulation now. It's 4 rods that go in the upper arm. It's equivalent to 8 milligrams of buprenorphine a day, and it lasts for 6 months. And it was studied in a stable patient population and really had good outcomes in that stable patient population. So I think there are more formulations coming out that allow patients more flexibility if they don't want to be taking something every day. But the problem is that even with a long-standing remission, the patient remains vulnerable. The brain chemistry has changed, and it seems that it may never, I mean, each individual is different, but it may never go back to opioid use balance. Yep. You mean, so in Kentucky, we can't, you can use the specific formulations that are FDA approved for pain, but Suboxone is not FDA approved for pain. And in Kentucky, we can't do that. But there are other states and VA systems, for example, that are using buprenorphine in their pain population. So I can't suggest that you do that here now. If our state regulations change, then maybe. I do think it's a much safer opioid, but there's barriers right now to doing that. Yeah. Oh, yeah. Oh, sure. I had some extra. Yes, yes. Get your X license. No, I don't think it's changing. Get your X license. It's really not a big deal to get it. You can take an 8-hour waiver training. This organization offers a free half and half. So the half, you can do 4 hours of a live webinar. You can do it at home in your pajamas. That's how I did it. Saturday morning, folding laundry. And then you do 4 hours of web-based modules, and then you take a little quiz, and then you submit the documentation of that training to the DEA, and they send you back your new DEA license that just has an X in front of it. Yeah, so in the hospital, you can use buprenorphine without an X license, but you cannot write the discharge prescription. So if you want to write a prescription, the patient's going to follow up with a provider in the next week or so, and you want to give them a few days of medication. You can't write that script until you have your X waiver. I also think the training itself is useful. It's helpful information to allow you to feel more comfortable managing this medication. It's really not any more complicated than the medicines that we use all the time in internal medicine. But I think because it's been pushed over to this special status, we get spooked. But it's so much safer and less complicated than a lot of the other medicines we use all the time. Yeah. So the use disorder. So opioid use disorder, mild, moderate, and severe. You can also write opioid dependence. So the actual ICD-10 codes are dependence, opioid dependence. Similarly for any of the other drugs, so alcohol use disorder, methamphetamine use disorder, cocaine use disorder. And that'll let you then code appropriately. Do you all do your own coding, or do you have coders? It's complicated. Okay. Yeah. But you pick the diagnoses. So what are y'all picking? Because if you just put IVDU or IVDA, it'll get pushed into this drug use NOS or something. I mean, then we don't know really retrospectively what was happening. Or it will get, or the coders will be forced to make inferences, and they're not supposed to do that. Yeah. Yeah. Oh. Withdrawal. Because you'll make them very, very sick. Okay. So particularly if you give them immediately the injectable formulation, you can put, if they haven't fully been through withdrawal and there's still any opioid stimulation on the receptors, you can put them through a really, really, really prolonged and miserable withdrawal, and they won't take the medicine again. They're not using naltrexone. They're using buprenorphine. So they see opioid withdrawal, and they give they give 8 milligrams all at once, and they figure if they have a precipitated withdrawal, they're in an ER, they can manage it. But no, they're not doing extended release naltrexone. Just the jails are, and some outpatient.
Well, thank you very much.
Yeah.
We have more people come up for questions, and we have 3 people in internal medicine that have the X license. So if you all need help with any of this in the hospital, we can help. And then I think the hospital and the ER and psych and everybody's working together to try to really address this opioid disorder. Just want to be part of that group that's working on it. Please let us know. And I want to thank you, Dr. Fanucchi. And here's a little Slugger badge.
Thank you.
Just for your
That's awesome.
Thank you all so much for coming. Really, really good. You have to check out this bat. Have you been to Louisville?
We haven't. We've been to the Children's Museum.
Oh yeah.
So it's right
It's right across the street.
Oh,
And so you're not flying or anything. Yeah, I didn't know exactly how they do it for every Grand Round speaker, and